Network, I'd like to welcome you to today's webinar, and the title is Precision Medicine in Oncology, Helping Guide Treatment Pathways for Clinicians and Patients. We'll be joined today by our two moderators, Bill Dempson and Rachel Mannion of 360 Public Affairs, along with our two subject matter experts, pathologist Dr. Diana Ionescu of the BC Cancer Agency and oncologist Dr. Paul Wheatley-Price of the Ottawa Hospital. In this webinar, the presenters will discuss how cancer care is increasingly tailored to individual patients who can undergo genetic or biomarker testing soon after diagnosis to determine which treatments have the best chance of shrinking or eliminating tumors. The presenters will also examine how they are using these new tests, how they communicate results and treatment options to patients and caregivers, and how patients can be better informed on the kinds of tests that are in development or in use across Canada. During the presentation, you'll have the opportunity to ask questions during an interactive Q&A session. For those of you who haven't attended an earlier webinar, this webinar is hosted by the Canadian Cancer Survivor Network. At CCSN, we work with patients, survivors, families, partner groups, and sponsors on collaborative action to identify and remove barriers to optional patient care, to ensure access to education and action opportunities, and survivor involvement in healthcare decision-making. And we support evidence-based research on ways to promote equal access to early diagnosis, timely treatment, and follow-up care. If you'd like to learn more about CCSN, you can visit our website at www.survivornet.ca. This webinar will be available online from tomorrow. There'll be full video on YouTube as well as slides on our SlideShare account. Links to both will be sent out to everyone who registered tomorrow afternoon. Thank you, Novartis, Merck, and Janssen for the generous support of this webinar series. Now, over to you, Bill.
Thanks so much, Mona. And just a quick sound check with you live. Can you hear us?
Yes.
Excellent. Thank you. And we've got the slide check. I think we are good to go. Mona, as usual, you've done a terrific introduction, walking through all the people who have logged in, and a reminder to you and to your communities that that this will be recorded and posted on the Cancer Survivor Network website so that you can view and share it later. The idea of doing one of our webinars on precision medicine and oncology started with a bit of research that we were doing at 360 on companion diagnostics. The idea that some new tests were coming and becoming available either in hospitals or externally that would help actually guide treatment pathways and sometimes be connected to a specific treatment itself. And it got us to thinking that the cancer survivor community, including advocacy groups, caregivers, and patients and survivors, would really be well served by understanding a little bit more about this very quickly evolving and changing landscape, and hearing from a couple of the people who are right at the cutting edge of working with patients in the clinics to help them understand what's available, why this is important in terms of precision medicine and oncology, and maybe what's next. And we're going to end the webinar with some open questions to the panel around what are the kinds of things that patients should ask their clinical care team, or to help guide their own research to understand what's out there and what's coming next. So with that, we're gonna actually walk through a few slides. We're gonna do this for about half an hour or 40 minutes. Please have your questions ready and feel free to type them into either the chat box at the bottom right or the questions box at the bottom right, and we will be able to follow them and put them out to the wider community or the specific panel. Please address them to either Paul Wheatley-Price or to Diana or to Rachel, who's going to be a panelist. So just quickly to recap what Mona said earlier, Dr. Diana Ionescu is responsible for clinical pathology at the University of British Columbia and the hospital in Vancouver. And Her specific areas of diagnostic expertise are in lung, gynecologic, and breast pathology, and a long biography in terms of publications and her expertise. And I understand she actually has some connections with and has worked with our other, one of our other panelists is Dr. Paul Wheatley-Price, who's joined us here in Ottawa, who's medical oncologist at the Ottawa Hospital, and just recently became president of Lung Cancer Canada. And so I understand Dr. Ionescu serves on Lung Cancer Canada's Medical Advisory Board. Dr. Wheatley-Price, as I said, runs a very busy clinic here in Ottawa, so we're really fortunate to have him and Diana on the line. They will be followed by my colleague Rachel Mannion, a senior associate at 360 Public Affairs, who co-authored an article on companion diagnostics. So we're gonna go into the clinic, go into the pathology world, and then come back out and understand a little bit more about some of the policy and reimbursement challenges around precision medicine and companion diagnostics. And I'm going to depend on everyone on the line and among the panelists to come up with some good questions and some good conversations. So with that, let's turn the panel over to Diana. Diana, how are you? Can you hear us loud and clear?
Yes. Thank you very much, Bill, for the introduction. And thank you to the Canadian Cancer Survivor Network for inviting me to talk to you today. I'm actually here to talk about the role of pathology and laboratory testing in the diagnosis and treatment of cancer, a subject about which I am actually very passionate. Although not always obvious to the patients and the public, pathologists are on the front line of cancer care. Pathological examination has been the gold standard of diagnosis of cancer for over a century. Since I started working at the BC Cancer Agency approximately 10 years ago, my role as a cancer pathologist has changed dramatically. This change occurred around 2007, and it was due to the discoveries of drugs that are effective only for certain molecularly defined tumor types, treatment that we now refer to as targeted therapy. One of the most exciting parts of my daily work is testing tumors to identify the best treatment for the right patient at the right time. Medical oncologists require increasingly specific information about each individual tumor for treatment decision-making. As pathologists, we're looking to identify characteristics of the tumor, or biomarkers, and therefore these tests are also known as biomarker testing. What are biomarkers? The National Institute of Health defined biomarkers as a characteristic that is objectively measured and evaluated as an indicator of normal biologic processes, pathologic processes, or pharmacologic responses to a therapeutic intervention. Biomarkers can be used to understand the pathobiology of the disease, for diagnosis, for disease monitoring, or as a specific target for drugs. Biomarker testing is a relatively new concept in oncology, but it is not specific to cancer drugs. And there are other conditions for which they have been developed, including cystic fibrosis, HIV/AIDS, rheumatoid arthritis and hepatitis C, and many other diseases. How can biomarker testing optimize patient care in oncology? Biomarker testing identifies those subgroups of patients for whom select drugs are likely to be most effective and safe. In fact, one of the pioneer biomarkers in oncology, about you may have heard about, it's the tumors receptor for estrogen, which we have been testing for in the laboratories since 1998 on all breast cancers and with a significant clinical impact. In Canada, the landscape of biomarker testing in cancer has been developed since approximately 2009 by multidisciplinary groups of medical oncologists and pathologists who worked together to develop and implement the best testing strategy for Canadian patients. We have to take into consideration not only the scientific results, but also the economic realities of our healthcare system, and I think so far we've been quite successful. To better understand biomarker testing in oncology, I thought I would be presenting you with an analogy of antibiotic treatment. Prescribing unnecessary antibiotics, it's a major healthcare issue. And you may have noticed ads on TV or even on the city buses making us all aware of when not to take antibiotics. Personalized care is not new to medicine. Actually, in infectious diseases, laboratory testing to assess the sensitivity of different infectious agents to various antibiotics is an established cornerstone in determining therapy. This well-established approach can improve patient outcomes, avoid side effects or inappropriate treatment, shorten hospital stay, and minimize unnecessary physician visits. Testing for the appropriate antibiotic therapy has also long-term outcomes. Testing helps limiting the antibiotic resistance, avoid healthcare complications, including death, and prevent unnecessary expenses. And this entire chain of medical events, it's more effectively and efficient because of the relatively inexpensive but highly reliable and specialized tests that are implemented in a timely fashion in the laboratory. As with antibiotics, a relatively inexpensive laboratory test can determine the best use of healthcare resources in oncology. Next slide, please. When it comes to cancer molecular testing, I think we are seeing a revolution that started with targeted therapy. The greater our understanding of molecular diversity of cancer is, the greater our awareness of their unique sensitivity and resistance to specific drugs. Therefore, the role of oncologic pathology is increasingly important with the introduction of these companion diagnostic drugs. In summary, I hope that I showed you briefly what we do as pathologists to help cancer patients, not only in getting the correct diagnosis, but also in identifying those cancers who may or may not benefit of specific treatments. Thank you very much for your attention, and I'm looking forward to answering many more questions during the question and answer period. Back to you, Bill.
Over to Paul.
Over to Paul.
Thank you very much. I hope everyone can hear me. Thanks to the Canadian Cancer Survivor Network and to 360 Public Affairs for inviting me to take part in this webinar. I'm a medical oncologist here in Ottawa, where I primarily treat patients with lung cancer, which is the deadliest cancer in Canada, with over 20,000 deaths per year. The 5-year survival rate is a fairly dismal 17%. And while lung cancer occurs most commonly in smokers and ex-smokers, there's also a significant minority of lung cancer patients who never smoked. So it is certainly true that if you have lungs, you can get lung cancer. And biomarkers are now helping us really personalize cancer care, and we're seeing this particularly in lung cancer. And I'm going to show you a number of examples of where this can make a difference in the clinic. And you've got some examples here of, that are listed on this slide, ALK, EGFR, and PD-L1, which I'll come back to in a minute. Go to the next slide. The biomarkers are being used primarily in cancer, but as you've also heard from Diana, that we're seeing biomarkers being used across the healthcare spectrum, but the predominant use of that is in cancer care.
Just a quick note, Matt, I understand you're controlling the slides now, so if you could just ask them to advance, and we actually can see it on this screen here. So Matt will be advancing the slides.
Okay, thank you. So if we could please advance to slide 18, the pre-biomarker era, the next slide, please. Thank you. So historically, in cancer treatment, we've used chemotherapy to try and control cancer, to slow the progression of the disease, to improve the quality of life of patients by reducing cancer symptoms. and then to modestly extend life expectancy. And these potential benefits, as you can see on this seesaw diagram, are weighed against the risk of side effects that can be experienced from chemotherapy. And those include fatigue, infections, nausea, vomiting, hair loss, hospitalization from various complications, and other potential side effects. And what made traditional chemotherapy challenging for both patients and clinicians is only having a fairly crude ability to predict the chance of benefit. So as you see across the bottom of that slide, I would tell patients with lung cancer when starting chemotherapy for the first time that there's approximately a 1/3 chance of a significant benefit, a 1/3 chance that we might just stabilize the disease, and a 1/3 chance that the drugs wouldn't work at all. So really unable to have any confidence or any high levels of confidence when starting these treatments. So if we move on to the next slide, please. Targeted therapies and the use of biomarkers to predict benefit has really revolutionized the experience for many, although not all patients.
So Matt, can you please advance the slide by one?
You're going to see a pie chart coming up in a moment with a breakdown of lung cancer subtypes, and many of them we have now been able to identify specific mutations that can occur. We call these driver mutations. So that is a dominant genetic factor of an individual's cancer that causes it to grow and spread. And for many, but not all of these mutations, we now have a drug that we can match to the mutation, and therefore we can treat patients with high levels of confidence. And there are many examples of genetic or oncogenic drivers now, particularly in non-small cell lung cancer, as you can see from this pie chart. And the most common one in green is the EGFR, or epidermal growth factor receptor. The other common one that we look for now is called ALK, just to the top there in the light blue, which stands for anaplastic lymphoma kinase. And these two molecular subtypes now have multiple tablet treatments that are well tolerated and allow patients to essentially live fairly normal lives for a period of time and far superior to chemotherapy. And if we move on to the next slide, you can see from this graph, this is called a Kaplan-Meier curve, and it compares two treatments. And then for the people who are taking those treatments, the time it then takes for the cancer to progress. The red line represents a group of patients who took one of these targeted drugs called gefitinib, whereas the blue line represents the group of patients who were treated with standard chemotherapy. And on average, if people took the targeted therapy, it was twice as long for the cancer to progress. And this is by taking a single, simple pill once a day. To make that, to put a patient's face on that, or a case on that, if we move to the next slide, this is an example of a 40-year-old man who was healthy, a runner, two young daughters who really active in dance programs, and he had difficulty seeing and ultimately was diagnosed with a lung cancer in his right lung, which had spread to the back of his right eye. We identified for him that he had the EGFR mutation, this biomarker that should predict the response to treatment, and he was treated with the drug gefitinib, which is the drug that I showed the example of on the previous slide. And within a few weeks, you can see from those scans, the left being before the treatment and the right when he'd been on the treatment for a few months, that the lung tumor has essentially disappeared and that his vision had improved within a matter of weeks. We move to the next slide now, please. Well, first-line treatments like the gefitinib that gentleman Mark had been taking, they don't last forever, but now we're able to identify new biomarkers that can emerge or new mutations. And so particularly for the EGFR example, the common reason that those drugs stop working is because a new mutation emerges. And now we can identify that with the help of our colleagues such as Dr. Ionescu. In this case, it's a specific mutation called T790M. And this can now also be matched to a new drug called osimertinib. Now this is a graph called a waterfall plot where each bar represents a single patient and what happened to their tumor after they took this drug. If the line falls below the midline, that represents the cancer shrinking. If it's going upwards, that's representing the cancer growing. So I think you can see here, particularly for the top half of that graph, if there's a patient with identification of this specific mutation and they receive this specific drug, osimertinib, we can go into it really extremely confident that the drug will be effective. And if we move on to the next slide, this is a picture of Mark and his wife, Natalie. And this is just to show that these graphs and slides that I show you, they're not arbitrary measures of a drug with some numbers that may not be meaningful. This is a picture of Mark and Natalie taken about 6 weeks after he started this drug, osimertinib. And he's arranged a surprise birthday party for Natalie, and there they are in a stretch limo. Before starting that drug, just 6 weeks before, Mark had been essentially bedbound and had a very limited life expectancy of maybe just a month or two at that point. So this is not just a treatment that has modest benefits. This is something which is meaningful and relevant for patients with that type of cancer. We could move on to the next slide. I hope I've been able to demonstrate that with biomarkers and mutations that we can identify in lung cancer, there is a great deal of hope for the future in treating many of these cancer patients. However, if we switch to the next slide, here we go. One of the issues that we have is the regulatory authorities being able to keep pace with the pace of change and development of new drugs. So while through conferences and media in the clinic, through social media, both clinicians and patients are fully aware of new drugs and their effectiveness, we often have to wait a long time, a year, 2 or more years, before there's public reimbursement of these drugs. And in fact, that's the topic of Lung Cancer Canada's annual Faces of Lung Cancer report, which was just published this month, explaining the long delays that we're seeing in getting drug approval. And I think we're going to talk a bit more about that in a minute with Rachel. There are other biomarkers that can help identify and guide clinicians in treatment that aren't a specific mutation, but that can help us. And over the last couple of years, we've really seen an explosion in the cancer world with new immunotherapy drugs. So these are drugs that allow the immune system to be sort of ramped up and tackle the cancer themselves. And in lung cancer, this is particularly 2 classes of drugs called PD-1 and PD-L1 inhibitors. Now, these are intravenous treatments, but they're generally much easier to tolerate than chemotherapy. And if they do work, then the effects can be very durable and give long-lasting benefit. But a challenge we do have is identifying which patients are most likely to benefit. And this is where biomarkers can help, but there is some degree of confusion. So the best biomarker is called PD-L1, and you can see that in the 2016 state of play over on the right. This can help identify patients who may benefit from a particular immunotherapy drug called pembrolizumab. But it's less helpful with one of the other immunotherapy drugs called nivolumab, which is just a bit further down on the right-hand side, highlighted in yellow. And given the number of lung cancer patients in this country and around the world who may be eligible for these treatments, and the potential cost, identifying a robust biomarker in this population is going to be extremely important. So, in summary, and as shown in this 2016 State of Play graphic, biomarkers are allowing us now to clearly identify more and more patients who can have safe and effective tailored therapies, be it EGFR, ALK, ROS1, which I didn't talk about, or PD-L1 or others. This is an exciting time to be a clinician in lung cancer and a hopeful time for patients. And finally, multi-gene testing or next-generation sequencing is currently available privately, and this is the ability to assess all of these biomarkers at one go. So undoubtedly that is the future of where we're going, but its utility in 2016 is unclear, particularly if we identify biomarkers for which there is no access to drug at the end of the day. So for now, the best use and the best role of this may be in identifying potential clinical trial opportunities. And with that, I end my portion, and thank you for your attention.
Thanks, Paul. Over to you, Rachel.
Thanks very much. Actually, Matt, could I ask you to back up 2 slides, please? So the one with the arrow, perfect. Thanks so much. So what you guys see in front of you is, as Paul was saying, this is the general pathway that drugs and biomarker tests follow in order to become part of the healthcare system and available to patients. So we start with the regulatory authorization, moving through health technology assessment, and then a decision about whether or not the government will cover the cost of the technology, and then the idea then being that it becomes part of the healthcare system and is available for patient access. When you look at the issue of companion diagnostics and the drugs that they are paired with, what happens is you actually have 2 different products, 2 different kinds of technologies moving down 2 parallel streams. So it becomes a bit complex for all of these elements to be met in order for patients to have access to the technologies. And this starts all the way back at the beginning of our era with regulatory authorization. So the tests are reviewed as medical devices, and the drugs are reviewed as drugs. And there's no real process within Health Canada to have those, there's no formal process, I should say, to have those reviewed together and have those 2 products move forward as one sort of integrated system. And then when it comes down to the next step, which is called health technology assessment. And I know some of you will be very familiar with this aspect, and this will be new for others. So what happens with health technology assessment is experts are asked to evaluate how effective the technology is compared to other options for patients. So that's from a clinical perspective. And then they're also asked to do an economic analysis of the technologies. And this is meant to give policymakers and decision makers a better sense of where this technology might fit into the great scheme of things. So when we are talking about companion diagnostics, to date, we haven't had a system that allows us to assess these technologies together, that allows these experts to look at both the drug and the device or the test sort of as one unit, and that would allow them to come up with a recommendation about both of those so that can go on down along the pathway. And now CADIS, which is the Pan-Canadian or National Health Technology Assessment Organization, they've just come up with a new process which I'm going to speak to shortly. So that should go a long way in helping to move a lot of these technologies forward and closer to becoming available for patients. Now, if I could ask you, Matt, to flip forward 2 slides, please. That's great, thank you. So when it comes down to the question of how different technologies are funded, it really comes down to an issue of what we call siloed funding. So in front of you, especially if you're in the prairies, this might look familiar, but these are big silos, and we've put labels on each of them to give you a sense of how in different healthcare budgets, these elements are treated distinctly. So you'll often have a budget for hospitals, and within hospitals, the drugs that are available and the laboratory services that are available and the different healthcare providers that work there. But when you come into the community setting, there's a different budget line item for drugs. There's a different budget for healthcare providers who work in the community. And there's also often a different budget item for laboratory services. So as you can see, as Diana and Paul were explaining, when you're using companion diagnostic tests to help determine the most appropriate treatment, you need sort of to rely on most of these elements, especially if you're in the community. You need You need pathologists and laboratory services to perform the testing. You need your physicians and your specialists to help guide your care, along with all of the other care team that you'll see and that will be part of your patient journey. And of course, access to drugs is also dealt with separately. So the fact that all of these are funded in different ways has proven to be a bit of a challenge to making sure that new treatments and their companion tests are available for patients to access. And if we could go forward to the next slide, please. On this slide, this is a graphic depicting what you'll see in the middle along that arrow is the current process that's used by CADIS for assessing drugs. And in particular, this is the process used by the Oncology program, or PCODR, the Pan-Canadian Oncology Drug Review, in order to assess new drugs and provide recommendations to different provinces, to the federal government as well, on whether or not the drug itself should be funded. And so what they've done in this new proposed process is they've figured out different stops along the way when information about the companion diagnostic can be handed over to the experts, and then that analysis can be integrated. So there's two, from a patient perspective, there's two interesting opportunities with regards to this new process. So the first being that this is a process that's just been proposed, and CADIS is looking forward to getting feedback, including from patient organizations like CCSN, on how this process will work, and in particular how patients can engage with this process once the process is live. So you'll see the second peach-colored box at the bottom. When it comes down to PCODR review, when the experts are actually analyzing the drug, there is an opportunity for additional stakeholders to provide input into this process. So some of you may have experience with the PCODR process as patients, providing patient input on a specific drug, on what that means for you and what that treatment, how that treatment may impact your care or the care of people in the group that you're representing. And so in this case, they'll not only be looking for patient input, but they'll also be looking for input of clinicians like Paul and Diana, so they can talk about the specific impacts of that test and that test and drug pair and how that might work in practice. And they'll also be looking for the actual implementation input. So what they're going to be doing is they're going to be asking the different healthcare systems, the different provincial governments, for any challenges that they might see with implementation. So it looks like it will be a fairly robust process, and this will provide the experts with a lot of interesting material to review and to base their recommendations on. So again, as I mentioned, this process that they've proposed, that is open for consultation currently, and then once the process is live, there will also be patient engagement opportunities on an ongoing basis. So that will be really interesting for everybody to bring forward some of their own experiences and viewpoints. Matt, could I ask you to advance to the next slide, please? So behind the actual pathway, that first arrow that we looked at together, there's all kinds of different policy initiatives that are shaping a lot of this work and are shaping the kinds of access that patients will have to these products and where and when that will take place. So on this slide, we've put a few highlights. So some of you may recognize the image just on the right of the slide, which is the report of the Advisory Panel on Healthcare Innovation. That came out over a year ago. I think it was actually about a year and a half ago. And in that, another group of experts, they looked at a bunch of different opportunities to innovate in the Canadian healthcare system. And one of the opportunities, looking forward to the future, one of the opportunities that they identified was the need for a national precision medicine strategy. So that would look at this evolving area. So companion diagnostics are an example, of course, of precision medicine, of tailoring medicine to individual patients. So they would they were looking forward and seeing this was on the horizon, seeing there are more and more treatments coming forward that rely on this kind of process, that rely on this kind of data, and looking at trying to coordinate this across the country. As we all know, as Canadians in being involved in the healthcare system, participating in it, sometimes it may not feel like it's the most coordinated experience. So this is sort of one initiative that aims to provide a bit more coordination and really look at making sure that these kinds of technologies are available to patients. And then when we look at different jurisdictions, specifically in the cancer context, we see that there are a couple of long-term strategic plans, specifically in the prairies, that are looking at developing their own strategy. So for example, in Saskatchewan, they're working on developing a molecular oncology strategy. So it's really interesting when we look across the country and we look at policy around precision medicine and around biomarkers, it's really the oncology systems, the cancer care systems that are leading the policy in this area for our country. So we'll see that in Saskatchewan, and then in Manitoba, both their cancer plan and their diagnostic services plan incorporate different elements of increasing access to this kind of testing and improving access to personalized treatment for patients, including in the pathology context. So that's also really interesting. So it's not just genetics. Sometimes it's about other kinds of tests as well. And then in Ontario, the fourth master cancer plan, that's looking, like Manitoba, that's looking not only at personalized cancer care in particular, it's also looking at different elements in the pathology context more broadly. So that's really exciting. There's all kinds of different initiatives coming forward across the country that will help to guide patient access to these kinds of technologies. We could go forward one slide, please. That said, there are, of course, different gaps and challenges in the policy landscape around these technologies. And so as we saw with that first arrow in our silos, there isn't really a clear and consistent pathway to get these technologies from their development, once they're available in the Canadian market, to get them all the way into being part of the healthcare system. The proposed process that CADIS is looking at implementing should help to pave the way for that to be an easier and more straightforward process. But there's still quite a bit of work that should be done in that area. As well, given the science behind these areas, there is a rapidly evolving knowledge both on the role of biomarkers and their place in terms of the broader treatment guidelines for patients. And of course, as the science continues to evolve, translating this knowledge in a way that makes sense and is useful for patients and healthcare providers, I might add, is an ongoing challenge, and that's something that patient groups are trying to really dig into and work on. As well, when we were talking about the budget, we didn't touch on the fact that the costs associated with these technologies are often can be focused on as challenges to sustainability of the budgets and of the health system. So the different kinds of health technology assessment processes and all of the other kinds of expert reviews should help to provide some guidance about the value of these drugs and these tests to the healthcare system and to patient care as well. And of course, we are still looking at, in Canada, we're still looking at exploring different kinds of opportunities or options for programs that will allow the development of an evidence basis surrounding those technologies and the collection of data around how those technologies, the drugs and the tests are examples of that, how those are impacting patient care and how they can be used moving forward.
Okay, so Rachel, any closing thoughts or remarks? We were just thinking about wrapping up the presentation portion of this because we got some great questions, especially from April Steele. Thank you. by not necessarily, well, we're going to get to your questions in particular, but putting it out to the broader patient, survivor, and caregiver community, some of the things that you can ask when you're dealing with your clinical care teams. You know, what biomarker tests are recommended and why? How are the tests performed? Some of them could involve gene testing versus biopsy testing of particular tumors themselves. How often you need to go and get tested to see if things are working, or try another product. What do the results actually mean in terms of validity and other criteria for actually interpreting the test? And how will those results affect the treatment pathways? And I think, Rachel, you gave a really good overview of how patients can actually engage in the policy discussions within their own clinical care communities, but also even at the national level. And I think that that's a great opportunity for groups like the Cancer Survivor Network or others, and many of you are on the line now. So I think we should probably turn it over to both the people who have some questions on the line, and I've got a few questions here just in case things get a little bit quiet. But please fill out your questions in the comment and question box in the bottom right. In April, I'm going to actually turn it over to you. I'm going to start backwards because I think your last question is most interesting. Then we'll work our way up if we don't hear from anyone else. April wants to know a little bit more about next generation testing. Maybe she meant next generation genome sequencing in Canada, or maybe there's a whole different, like what's next on the horizon for this kind of personalized medicine. And Paul, do you have some thoughts on that? And then we'll turn it over to Diana.
Yeah, so a couple of comments on that. Firstly, I would just suggest moving forward with caution, because for the actual relevance in the clinic, next generation sequencing may not have an advantage right now over testing for just isolated specific biomarkers such as EGFR or ALK in lung cancer. What next generation sequencing can do will test for hundreds of potential mutations and will often identify some, but those mutations do not necessarily mean that we can treat them if there's no drug that matches that. Or, which can be also difficult, there is a drug that we think matches that target or that biomarker, but we don't have access to it. So although it can help if we find that a mutation, we may be able to match that with a potential clinical trial of a drug that we think would work. So there is some utility in the research field, but as a general practice, we haven't been doing it a lot. It is possible to do next generation sequencing. The most commonly utilized pathway for that is a group in Boston called Foundation Medicine, which is a private pay test. There is a group in Vancouver called Contextual Genomics. They are, I don't believe they're currently publicly available to get the test. They're in a pilot phase where they're offering tests to for clinicians to order. One thing that I would say that I think is quite exciting, and we can maybe a peek into the future, is there is increasing research evidence that some of these biomarkers can now be detected in blood or urine. So right now, if I want to find evidence of a new mutation, for example, the T790M that we mentioned earlier, I have to coordinate with radiologists and pathologists in our molecular lab to arrange new biopsies and new testing, and that can take many weeks to get through that process. But certainly in the future, we can see the time when a blood test or a simple urine test might be able to answer the same question, and so that is clearly quicker, cheaper, and safer. So I hope that helps.
Diane, do you have any thoughts on the next generation sequencing or the peek into the future that Paul mentioned?
Sure. Maybe I can comment a little bit on the present and a little bit on the future. So usually I tend to think that more information is better. But this time I think that Paul and I agree that having new generation sequencing information that provides us with the mutational status in tens or hundreds of genes may not be practical. for the reasons that Paul mentioned before, us not having really drugs related to these particular mutations. So I think that although new generation sequencing is great, it's definitely a very comprehensive test, may not always be the most practical solution. I also, as a pathologist, would like to mention that it's new generation sequencing, it's not a test that will offer you results on all the driver mutations that Paul talked about. And if you remember his pie chart, there were a number of mutations such as ALK translocation or ROS. Those are not identified by new generation sequencing. There are other tests, for example, fluorescence in situ hybridization or immunohistochemistry, that needs to be performed often in parallel with new generation sequencing in order to identify those particular mutations. For example, PD-L1, which is the biomarker for immunotherapy, it's an immunohistochemical stain. It's a completely different way to look at the tumor than new generation sequencing is. To go back to the initial question, where can we get next generation sequencing testing in Canada? There are several major academic laboratories who are actually doing new generation sequencing in the form of so-called panels. So varying from approximately 20 to 40 genes, new generation sequencing is performed in Ontario, Quebec, Alberta, British Columbia, in the clinical setting, and provide this information to clinicians. On top of these academic centers, as Paul mentioned, we have Foundation Medicine, which is actually now in Canada as well, has a Canadian branch, and other private laboratories, although there are many, many fewer in Canada as compared to the United States. And one last thought about the future and about the availability of identifying biomarkers in plasma and urine. This is a very exciting area to look at. The only caveat that I would like both patients and probably the payers to know is that those tests have a relatively high proportion of false negative tests. So in other words, if a plasma or a urine test is negative, it doesn't 100% mean that the tumors don't have a mutation. Therefore, as a plan B, we are always thinking of testing the tumor itself if a plasma or a urine test it's negative. But for those patients with positive tests, I agree it's a huge save in time, anxiety, resources, and it's probably the way to go in the near future. By the way, plasma testing is also available in several laboratories in Canada and definitely in the United States.
That's very exciting. Thank you, Diana. We've got a few other questions on the line, but before we get to them, I just want to briefly ask you, somebody comes into your clinic who's presenting, or you suspect that there's a tumor. How does it actually work, and how would you work with somebody like Diana in your hospital, and then report back? Like, how does that actually work in practice?
So mostly for oncologists, we meet people when they've already been diagnosed with cancer. So the biopsy's already been done and the diagnosis is there, and then at that point the referral comes through to see the oncologist. And most of the time, the pathologist will have identified that this is a lung cancer or this is a breast cancer and have already performed the appropriate molecular testing to identify those biomarkers. So in Ottawa, in our clinic, when I see a new patient with lung cancer, I'm likely to already have the information about the biomarkers that I can immediately act on. And those really are the EGFR and the ALK ones for us now, because we have a funded, targeted drug to match that biomarker mutation. For the other biomarkers like PD-L1 or ROS1 or a number of those others that were on that pie chart, those are not routinely tested because, to Rachel's point, with the drug approval process, those drugs and the companion diagnostic are not yet approved by the regulatory authorities. When that happens, then we'll be working with our pathologist to add those biomarker tests. So I'm quite fortunate as the oncologist, when I sit down with someone with a new diagnosis of lung cancer, by and large, all the information that I'm going to need to help make the best decision is there on the paper in front of me.
Diana, does that are you the flip side of that coin, or how hand in glove do you work with the clinical team?
We have an extremely close relationship and communication with the medical oncology team here in British Columbia. It's probably one of our strengths, actually. Unfortunately, because of regulatory and payment differences in different provinces, it's very unlikely that pathologists are allowed to order this test as a reflex test, meaning for me to perform mutational testing at the time of diagnosis. In many provinces, we actually have to wait for a specific request from the clinician before we perform the test, otherwise the test is not reimbursed. That definitely brings up a huge delay in patient care that we've been trying for many, many years to sort out, sometimes successfully, sometimes not. And this is where definite patient advocacy can help us. I think as a pathologist, one of the most important things that I have to be aware of is to make sure that the test that we provide is reliable, accurate, because once it gets to the clinician, it really starts a domino effect. If this test is positive, the treatment goes on, and sometimes it can go on for many months or many years, sometimes with possible side effects. So for me as a pathologist, it's very important to make sure that when I say that something is positive or negative for that matter, I'm hopefully most of the time correct. Also, the management of the tissue, it's something that I think we as pathologists have to be very aware of. In lung cancer patients, for example, when 75% of them present at advanced stages and will never have a surgical specimen, which means a big resection specimen, we are working with very tiny pieces of tissue, and therefore we have to have a very accurate testing algorithm to test for those biomarkers that actually have a practical applicability today for that particular patient.
So, Diana, we have a question. Thank you for that. We have a question from my friend Dennis Morris around the approximate cost, and you know, thought we'd throw it to you or to Paul in terms of the range, because it can range, I guess, from a straight biomarker test to, you know, the full genetic panel and what Foundation would charge. Do you have any thoughts on costs for these tests?
Are you asking me or Paul?
I'm going to start with you and then turn to Paul if there are gaps to fill.
Okay, depending on the type of testing, the price can vary quite a bit. Usually the least expensive tests are the immunohistochemical stain tests, for example, PD-L1, HER2/neu in breast cancer, ER/PR in breast cancer. Those we're talking a few $100s, and the price of those tests is mainly based on the price of the antibody. So some of these chemicals can be very expensive, some of them can be less expensive. When it comes to molecular testing, the larger the panel, the more expensive it is. When we were to if we were to talk numbers, the testing of EGFR, both in the tissue and in plasma, ranges somewhere between, I would say, $400 and $600. I may not be exactly accurate. I'm just really giving these numbers as an example. But when it comes to very comprehensive tests that look at hundreds of mutations, such as the Foundation Medicine test, we're talking about $3,000 to $4,000.
maybe I could just add one point to that, which is at some point in the next year or two, we're going to reach a tipping point where it becomes more effective to do a next generation sequencing panel rather than sequential individual tests. And there'll be an inflection point where it becomes cheaper to do the full panel. And further, the cost of doing those full panels will come down over the coming years, and you can get a hint of that by the cost of something like 23andMe, which is only like $99 or $199. So now I would not recommend doing 23andMe for cancer testing, but I think it does illustrate that the technology is moving so quickly that we will be seeing in the future that it's cheaper to do next generation sequencing, and certainly cheaper than doing multiple sequential tests.
Excellent. Thank you. We've got a couple of specific questions from listeners, and what I'd encourage you to do, actually, Matt, if you flip to the next slide, I've got my email address up there. In terms of fish testing in Ontario that was actually denied in terms of reimbursement or funding for that, which is of concern. And then a second one in terms of where individuals or clinicians could find information about labs in Canada that perform the serum or urine biomarker testing. Not that we can get you all the answers, that we're running out of time, but any quick thoughts on that while we...
Well, so the serum and urine testing, that's a research question right now. So that's not something that is routinely available, and it's not something we would recommend at this point.
Thanks. In some ways, that brings me back up to April. One of your original questions was, what specific things can survivors advocate for in order to expedite regulatory approvals of some of these diagnostics or availability? And I think we can think of regulatory in two ways. One, in terms of Health Canada approvals, and second, in terms of reimbursement or health technology assessment recommendations to support reimbursement. Rachel, you did a great job of highlighting that the Canadian Agency for Drugs and Technologies in Health is actually reviewing this whole area. And I'll just throw in that Health Canada is very active right now in terms of regulatory modernization, especially in oncology. They're looking at some of these treatments that are more targeted than ever, that don't have standard data sets to support regulatory approvals because they're so targeted at individual tumors. For patients, it's important to be able to get access to this early, especially in when they're right at the wall of potential mortality or some survivorship. And I know that Paul, you and your team at the Ottawa Hospital have been pretty involved in terms of access to life-saving therapies, and getting the access to both the test and to some of these treatments a little bit earlier in that life cycle. Is something that some of your colleagues at least have been advocating. So maybe last word to you, and then we'll wrap it up.
So I think we have to look at this, that we are a community. It's not clinicians doing the work or researchers or just patients or patient groups. We already have to work together on this. And it's certainly true that with the current regulatory delays, and I think they are delays, people are losing their lives, and we have examples of drugs that were available publicly in the US 2 years ago, and we're still waiting for approval here in Canada. And that people are dying. And so I would encourage you to join groups like the Canadian Cancer Survivor Network, CPAC, Lung Cancer Canada that I represent, and other groups. And together, as we try and build a community, we can advocate with the federal government, with CADTH, with PCODA, with Health Canada. And we're going to have to come together on this. And I think, Rachel, you indicated that there is some movement to do this already.
Yeah, definitely. In the health technology assessment area, there is, and just building on their point, on everybody's point here this afternoon. Even beyond regulatory approvals, maybe taking a broader look of what that means in terms of getting treatments to patients. There were those examples on the slide there about different strategies that are being developed in different jurisdictions. So there may be some opportunities there for survivors to share their experiences and to do some advocacy work around shaping the direction in different provinces as well.
Okay, so with that, a real special thanks to Diana on the West Coast for taking time out of clinic, for Paul, who has another appointment in a very short period of time here, and to Rachel for the expertise that you've all brought to this big challenge, and especially to the Cancer Survivor Network, Jackie, Mona, Matt. Really appreciate the opportunity to walk the community through this and remind everyone that it will be webcasted or available online for later use or dissemination. Back to you, Matt and Mona.
Thank you. That was a wonderful webinar. I feel very informed, even though I'm right in the middle of this and usually know something. These things are always adding to our knowledge base, especially as patients. We like to get more information all the time. This webinar is hosted by us, the Canadian Cancer Survivor Network. If you want to learn more about us, visit us on our website, www.survivornet.ca. And we have been a couple of times mentioning during this webinar that there should be patient opportunities for input into these kind of decision-making that's going on around all kinds of things in healthcare right now. And I would advise you to have a look at our website opening page. On the right-hand side, there's a column called Participate. Anything we hear about, from drug trials to input on Health Canada, different things that they ask for input on, you can find out things there about where you personally can participate, intervene, have opportunities to have your voice heard. That'll be on www.survivornet.ca. We'll be online tomorrow with this webinar, a full video on YouTube, and our slides on SlideShare. Links to both will be sent out tomorrow afternoon to everybody who registered, and the links will be available on our opening page. Thank you again, Novartis, Merck, and Janssen, for your generous support of this webinar series. And thank you to our participants today, Bill Dempster and Rachel Mannion of 360 Public Affairs, pathologist Dr. Diana Ionescu of the BC Cancer Agency, and oncologist Dr. Paul Wheatley-Price of Ottawa Hospital, and of course all of you who attended and listened in from coast to coast in Canada and from Sweden. Thank you. And this is the end of today's webinar.